Hi, I'm Sarina Schrager. I'm a professor of family medicine at the University of Wisconsin Department of Family Medicine and Community Health. Today I'm going to talk about menstrual disorders in adolescents. So my objectives describe the common presentations of abnormal bleeding in an adolescent, evaluate essential steps to determine the cause of bleeding, and formulate a treatment plan when a patient presents with abnormal bleeding. So menarche happens, which is the age of the first menstrual cycle, about 2 years after the beginning of breast development. Menstrual cycles initially are anovulatory, and up to 85% are still anovulatory 2 years after menarche. It takes up to 5 years post-menarche for people to start having ovulatory cycles. And because of that, anovulation is the most common cause of irregular cycles for the first few years after menarche. This slide gives you a very complicated view of what happens, looking at GnRH and LH, and how the hypothalamic pituitary axis slowly matures into developing ovulatory cycles. So the most common causes of abnormal bleeding in adolescent, like I said, anovulation is the number one most common. Heavy menstrual bleeding is also seen quite frequently. And then the third is amenorrhea, and there's primary amenorrhea in this population, and it has a very complicated and distinct evaluation, and it's really beyond the scope of this talk today, so I'm not gonna focus on it. So most of what I'm going to say is looking at anovulation and heavy menstrual bleeding. So your initial evaluation of abnormal bleeding in an adolescent will start with detailed history and physical. You don't necessarily have to do a pelvic exam at this point, because you're not really going to gain much, and for a lot of young women, that can be a big barrier to getting care. Most of the time, you'll look at a CBC, a TSH, and a pregnancy test. If the menses is irregular, you can consider having the patient do a symptom diary, so a monthly diary to get a sense of how often they're having periods, whether they have premenstrual symptoms. That would give you a clue as far as whether they're ovulatory or anovulatory cycles, and also just helps sort of give the patient a sense of what's really happening. I hear a lot of people coming in saying, oh, my periods are irregular, and then when you have them do a diary, they're maybe off a day or two every month, and it really fits within the normal range. So anovulation, you might want to think about ruling out other things, which is why doing a TSH can be really important. The other thing is looking at thinking about PCOS. We don't usually diagnose PCOS this early, but if if an adolescent patient comes in with symptoms of hirsutism, that might be part of your differential. For people coming in with anovulation, you've ruled everything else out. They've done the diary. It really shows that their periods are very irregular. There's really no treatment necessary, and reassurance. You can go a long way just saying, hey, this is really common after menarche. A lot of cycles are anovulatory. Let's just wait and see. But if somebody's upset about it, or they're worried about it, or they're having intercourse and you don't want them to get pregnant, this is a common reason that adolescents often start on combined oral contraceptive pills. You can also think about an implant or a hormonal IUD to manage cycles, to give them the reassurance that just because they don't have a period for 3 months doesn't mean they're pregnant. They have the reassurance of hormonal contraception. The combined oral contraceptive pills can be nice in that they have a predictable period. The other methods provide excellent contraception, but don't manage the cycle in the same way. Okay, so here's a case example. 17-year-old presents with heavy menstrual bleeding, lasts 7 to 10 days every month, accompanied by severe dysmenorrhea, and she's changing pads every few hours. She misses 2 to 3 days of school each month. She's adopted, so we have no family history, and she's not sexually active. She has no other medications or medical conditions. So thinking about somebody with heavy menstrual bleeding, um, assessing the amount that somebody is actually bleeding is exceedingly difficult. There have been lots of studies showing that people's assessment of their amount of bleeding is wildly divergent. Some people will do like a pad count or a tampon count. Usually you can say if you're changing your pad every more than every 1 to 2 hours, if you're changing your tampons, but still you're not really getting an accurate sense. So a lot of times the first line would be doing a CBC. So you're going to look for anemia. And that's one of the ways I use to triage. Is this person really bleeding heavily, or is it they just are bleeding heavier than they used to and heavier than they think they should? The other thing about a CBC is you can assess platelets. So in a very rare instance, you may be able to diagnose somebody with a platelet disorder. You also might want to think about a PT-INR and a PTT to evaluate coagulation factors. Interestingly, this is one place where family history can be really helpful. And that if there's a family history of somebody with a bleeding disorder, you may think a little move von Willebrand's disease higher up in your differential. This is not terribly common, but certainly something to exclude and rule out if somebody is having heavy menstrual bleeding. Certainly other signs of bleeding, like with brushing teeth or blood in the urine, would be significant to consider. So when do you think about screening for a coagulopathy? And these tips I think are pretty helpful for me. Obviously, family history, bruising or petechiae, other signs of bleeding, presence of anemia, and then really historical record of heavy menstrual bleeding. Um, uh, so treatment in this situation, if you have somebody with heavy menstrual bleeding, scheduled NSAIDs significantly can decrease the amount of bleeding. So a couple studies have shown that, scheduling either your ibuprofen or your naproxen can decrease the amount of bleeding by 30 to 40%. Tranexamic acid is another way to really decrease the amount of bleeding. Combined oral contraceptive pills both regulate your menstrual cycle and induce some endometrial thinning to actually decrease the amount of bleeding. And the patients I've had in the past who have had von Willebrand's disease end up starting on combined oral contraceptive pills early on and then continuing on pills until they desire pregnancy. A progestin IUD it has a lot of benefits, and it provides contraception, and also it induces local thinning of the endometrium because you are releasing progestin into the uterus. So it can be a really powerful tool in decreasing heavy bleeding in adolescents. There is the issue of discomfort with insertion of progestin IUD. So a lot of my patients end up starting on combined oral contraceptives first, as to see if that'll work. And then we talk about a progestin IUD for the future. You can do cyclic progestin in somebody who can't take estrogen. And certainly last resort would be a surgical intervention for acute bleeding episodes. Some people might need a DNC. But in this adolescent age group, that's very, very rare that would be necessary. This case follow-up, everything was negative. We treated this patient with scheduled NSAIDs, started on combined oral contraceptive pills, and they followed up in 2 months, had significant decrease in bleeding. We talked about tranexamic acid if their bleeding started increasing again. Here's some references. Thank you very much.